So thank you for joining us. It's a pleasure for me to introduce Dr. Rachel Poe. She's a board certified obstetrician and gynecologist, and after her residency, she completed a fellowship in global women's health and served as the medical director of the Fistula Care Center before returning to Cleveland, Ohio. She is the chief of the Female Sexual Health Division and part of the Gender Care Program in the Urology Institute at at University Hospitals Cleveland Medical Center. Her clinical practice surrounds female sexual health, menopause, vaginal reconstruction, and gender affirming surgery. And her research interests um, surround menopause, female sexual health, and sexual reconstruction. So if you would like to put any questions in the chat, please go ahead and do so, and we will get to as many of those as we can. But let me kind of back up a little bit, and because this is really important. Her research interests also include health disparities and social determinants of health. Okay. All right. So,
Thank you.
Dr. Pope, oh, you're welcome. Let's talk about menopause and some basic information. What is perimenopause and symptoms to recognize and look for? And what are the differences between peri and postmenopause?
These are great questions, and I did prepare some slides. So I hope I don't bore you guys all at 7:30 in the morning by showing you slides, but I have some illustrations here that I felt like would be important or helpful at least to kind of illustrate the point. So I'm happy for anyone to interject. If you have a question, please feel free to interrupt me. Or put it in the chat. I'm not great at seeing the chat questions, so I think Dr. Conklin will be monitoring that, but otherwise I have no problem if you want to just interject and ask a question. So I like to start off these illustrations with an example of a patient. So this is just a made-up patient, HT. She's 46 years old, and she came into my office saying that she just doesn't feel like herself. She said she's having a hard time sleeping. She feels like she's got brain fog, and her menstrual cycle is changing, where things are getting more heavy and a little bit more irregular, where she just can't predict them. She's also noticed that she started to have worsened anxiety, so much to the point that she went to see her primary care physician, who started her on escitalopram, 10 milligrams last month. And so she comes to see me to find out if there's something more, because while she knows that it might take 4 to 6 weeks for that medication to work, she feels like that's not the whole picture for her. So really, a lot of us know what menopause is. This is the permanent sensation of menses. So 12 months of no period is when we get a clinical diagnosis of menopause. Or it can happen earlier for people who've had oophorectomy surgically done, who've gone through chemotherapy or radiation that basically stops the ovaries from functioning. But we may not realize that the average age of menopause is 51 to 52. And so if perimenopause is the time leading up to that, so what we see is that the ovaries start to actually lose their functioning ability. They're producing fewer follicles, and that ends up with a cumulative loss of estrogen, progesterone, and actually testosterone. That starts even 10 years before that average age. And remember, this is just an average age. So if on average we're seeing menopause at 51, perimenopause can start as early as 41, but some women go through this earlier. So if, say, she's going to go through menopause at 48, which would be perfectly reasonable and not considered abnormal, she might start experiencing perimenopausal symptoms at 38. 2 million women enter menopause every year. And now, because of how well we're doing as a human species, I would say 30% of women, or 30% of a woman's lifetime is now spent after menopause. So then what's perimenopause? Like I mentioned, it's that up to a decade before menopause. And for everyone, it's a little bit different. And that's what I want to kind of explain in this talk this morning of why is it so different and why are people's experiences so different? So I describe it like a roller coaster. It's a roller coaster of hormones. There's these ups and these downs and these increases and these plummets, unless you're on something like a hormonal birth control pill or something that is suppressing ovulation. Like I mentioned, it can start as early as 10 years prior, and we see estrogen and progesterone fluctuations affecting every organ system. So we have estrogen receptors in really from head to toe. And so we see women who start to have migraines or worsened migraines than they had before. They might feel exhausted, their energy is changing, their hair, their skin, their nails are changing. Some people start to experience new GI symptoms. A lot of women start to notice that they have a lower sex drive, which we think is because of the decreased testosterone too, or they're experiencing vaginal dryness and that's causing them to have pain with sex, which is also then decreasing their drive. We see bone health start to decrease here. We see weight changes, which we'll talk a little bit more about, muscle pain, joint pain, of course, hot flashes. Those vasomotor symptoms is what we what so many people commonly associate with menopause and perimenopause, because I think it's a little bit easier to talk about, right? It's not as stigmatizing or as difficult to talk about as low sex drive, right? Then we see mind and mood changes, and this is where I've called on the help of Dr. Conklin. I would love to hear her experience today too, as a psychologist, because we see women start to have anxiety for the first time or have worsened anxiety. We see brain fog, these memory changes where I have patients coming in asking if they have early onset Alzheimer's because they can't remember someone's name that they've known forever, right? So from head to toe, we see these things change or start to happen. And as a gynecologist, I just have to give a dedicated slide to genitourinary syndrome of menopause because we start to see these changes in perimenopause too. And where on the left side, sorry, the graphic didn't come out as clearly as I hoped, but where these soft folds in the vagina otherwise used to be, that would help to elongate the vagina. And where we saw more blood flow because of the estrogen being there, we start to see a thinning of the vaginal wall and a flattening. So things become more dry and more stiff. And so women start to have pain with intercourse that they never experienced before. They might have urinary tract infections because of the change of the vaginal pH, or they start to have bladder symptoms like incontinence or overactive bladder. And we think all of these things are related to hormone changes. I love this graph. This was published not that long ago, but if this is the time of menopause, this time 0, you start to see where all of these symptoms show up. And let's look back. This only goes back as far as 4 years before menopause, but all of this side of the graph is perimenopause. And so you see the cognitive symptoms start to show up. The sexual and urogenital changes starting to show up, the sleep disturbance to start to show up. All of these things start to kick in and they are subtle. So I have some patients who come in and say like they didn't realize it right away until the things got so bad. Or some people who say like, I've never had this symptom before, so it's really throwing me off. So why is this happening? We talked about the fluctuations of hormones and what we see again, same similar graph where 0 is the time of menopause. And you look for those years leading up to it, how the levels of estrogen or estradiol here are slowly decreasing. We know that's the same for progesterone and testosterone as well, but it's not a slow decline. And again, this is where I bring back that analogy of the roller coaster. Look at this section of perimenopause where we're looking at estrogen and progesterone. It is an up, it is a down, it is an up, it is a down. And that is where I feel like the symptoms come from. It's that plummet. People are feeling okay when their estrogen starts to kick back in, beginning at the first day of having their menstrual cycle, things start to kind of increase gradually. But then when they get to that week before their menstrual cycle, where they might have just had some very mild PMS symptoms, now they are being plummeted into lower levels of estrogen as they ever have before, and they are feeling it. So that's really where I want to focus in today, kind of talking through menopause and perimenopause. And I hope you don't mind me asking the same question because I get this question a lot. Should you do blood work to diagnose perimenopause? Well, I love this example, so I'm sorry if you've heard me say it before, but if you think back to puberty, or if you have a 13-year-old, a 12-year-old child at home, or somebody, right, who's going through that, you see the changes of their body, you see acne showing up, hair growing up, their voice changing. Would you do blood work during that time? Probably not, right? You know this age and the physical signs and symptoms. So unless it's going to change your management, you probably don't need to do blood work. And because of this graph, this like very confusing up and down, blood work is going to be just as confusing. So I have patients who've come in and said, well, my estrogen was this, my progesterone was this, and then 2 weeks later, it was this other number. And I'm like, yeah, exactly. So we are seeing a snapshot of that roller coaster, but why, like, it's not going to help us make decisions here. So I wouldn't even bother doing it. Or you will see people who advertise saliva tests and urine tests that try to get a snapshot of these hormones. And then my patients come in to show me, well, it showed my progesterone was bottomed out and very low. So they started me on progesterone, right? And I don't believe that that makes clinical sense. I believe that the symptoms are what's more important, and we should be offering treatment based on symptoms. So what is that treatment? Is it okay if I talk a little bit about treatment? Or does
Oh,
anybody have any questions at this point?
yes. Uh, So, Dr. Pope, in terms
Yeah,
of like, perimenopause, and you mentioned like a lot of different changes that a woman will go through. Does every
yeah.
woman go through that?
Ooh, that's a wonderful question. So I think not every woman experiences the symptoms of it, and we could liken it to PMS, right? So I think most women kind of know what you're talking about when you say PMS, whether that is for them cramps or a migraine
Mhm.
or just feeling off. Right. And so a lot of people kind of will have a different life experience because we all respond differently to hormonal fluctuations. And there are some people who say, I know when my period's coming, but I don't really have bothersome symptoms, right? And so I think that there are people who have some of these changes, but it's not necessarily bothering them.
Okay, no, that's helpful. And there is a question here. Someone says the tinnitus is driving me crazy.
What is?
uh,
Oops, sorry.
tin- Tinnitus. Oh,
Oh, tinnitus. It's
tinnitus. Yeah, I thought I
or
pronounced it, yes,
tinnitus,
correct.
like ringing in your
Tinnitus, yes.
ears.
Hmm.
Right? I see a ENT. I actually interviewed one of our nurse practitioners who's an ENT at UH recently about changes in the ear, and actually lots of things come up in perimenopause and for reasons that we don't completely understand, right? Some things we do understand. People get dry or itchy ears, and we think that's similar to how women get dry, vaginal mucosa, dry eyes. All of these things are associated with the lack of blood flow that estrogen otherwise was providing. But why people are starting to get tinnitus or ringing in their ears may be more neurologically related. And so I would definitely see an ENT for it. But we see these things show up that, weren't happening before. And now for a lot of women in perimenopause, what women tell me is that they start to notice it the week before their period. And then they start to notice it 2 weeks before their period. And then eventually they're noticing it all the time. And most likely it's because finally the estrogen levels have gotten to be low enough that they're symptomatic more often days than they're not.
No, that's really interesting. Mhm.
Um, And then let's see, correlation with symptoms for menstrual cycle and perimenopause or menopause severity. That's a great question. So it's variable, right? Because we have a lot of women who have debilitating menstrual cycles because of endometriosis, and they might do great through menopause because finally they're getting a little less of those hormone triggers of their pain, right? But definitely, if you are a person who's had PMS or premenstrual dysphoric disorder, so even more severe, where you get severely depressed before your period, you are at high risk for having depression throughout menopause. And so you are somebody that I say, like, I urge you to get linked up with a psychologist, someone like Dr. Conklin or a psychiatrist. Because we know that your brain is unfortunately vulnerable. Same thing for women who've had postpartum depression.
Mhm.
We see that again, it's a very low estrogen state. So you go from being in a very high estrogen state during pregnancy and then this huge plummet, especially if you're breastfeeding, that continues a low estrogen state. And so we see postpartum depression being linked to depression and menopause as well. So all of these things, you could think back to if you've had a postpartum experience and you said, oh my, yeah, I had hot flashes then. or yeah, I felt more anxiety then, or I had tinnitus, right? All these things, then you know that that is probably a preview for what might be coming in menopause when you're in another low estrogen state. So I encourage people just to kind of be proactive with your care and get linked in with the healthcare providers that can help to really mitigate those symptoms for you, and get you treatment sooner rather than later.
That's good points, Dr. Pope, because you had mentioned earlier about, the referrals that you sent to me, and that's,
Mhm.
what to kind of like look for, or like a timeline of hormone sensitivity.
Right,
And if there is a past history of a mood disorder or anxiety, because we know that neurotransmitters and hormones are linked together, they kind of work
exactly.
together. And some women, as you had already mentioned, are more sensitive to this roller coaster of hormone fluctuations.
Right, exactly. Right. Some people love roller coasters, some people hate them. It's kind of the same. I love a good analogy. So maybe I'll talk a little bit about treatment, because I think it is important for people to know there's hormonal and there's non-hormonal treatment. And if you are experiencing something that is happening right before your menstrual period, you have options. You can either suppress your period with a oral contraceptive pill, or you can kind of supplement the estrogen decreases that you're experiencing through menopausal hormone therapy. And I find my patients who have had bad symptoms or bad side effects from hormonal birth control pills do really well with menopausal hormone therapy during perimenopause because it's a much lower dose of estrogen. So your ovaries are still providing some of the estrogen and progesterone, and then the treatment that we're giving you is kind of just supplementing it. Whereas a birth control pill suppresses your cycle and can prevent those changes too, but might not it might give you additional side effects, I guess, which is what I see for some of my patients. For just standard hormonal therapy, I usually recommend an estradiol patch. Transdermal estrogen is much safer. It's not associated with as many or as frequent blood clots or stroke. Micronized progesterone, if you have a uterus, is essential to protect your uterus from the estrogen. So I will find patients who've gone to compounding pharmacies and are using transdermal progesterone. We don't have evidence that that protects the uterus from estradiol the way that micronized progesterone orally does. We do have good evidence that Mirena IUD is helpful to protect the uterus from estradiol. And so if you have an IUD for contraception, I'm sorry, one second. Then that's reasonable to continue using. And if you are in perimenopause, you do still have to keep contraception in mind, right? You can still get pregnant, and we don't want to have an unattended pregnancy. The other contraceptive option that I offer for many of my patients who want an estradiol patch because they didn't do well with birth control pills, is to give them Slind or drospirenone for contraception and along with an estradiol patch. These are non-orthodox things, but I think it's important to know that, there are options for people. And then, of course, if you have medical contraindications for hormones and you're suffering from vasomotor symptoms, we've got two, recently FDA approved medications for vasomotor symptoms. And then if you have other issues like mood changes along with your vasomotor symptoms, then paroxetine is also FDA approved for vasomotor symptoms. But for all those other symptoms that we kind of talked about, we are lacking in non-hormonal treatment. So people always asked about the safety when we talk about treatment of hormonal therapy, and the Women's Health Initiative really terrified a lot of us from using estrogen for women. But the slide I think is most important to show you, this is borrowed from Ishwish, is that this age group, this early uptakers of hormone therapy. So they went through menopause at age 51 on average, right? And so if we're looking in this first 10-year window of menopause hormone therapy, we actually see decreased risks of coronary heart disease, decreased risk of or associated outcomes of breast cancer, and not nearly as high rates of stroke and venous thromboembolism as we see with the women who are in the older groups. And so the issue with the Women's Health Initiative was when these results came out, they lumped everybody together and showed that there was an increased risk. But those increased risks were really mostly associated with women who are on average age 63. So for women who are earlier in their menopausal journey or in perimenopause, we do think that it is a much safer time to start hormones and is kind of a window of opportunity. But
Yeah.
to get into the meat of the topic today, we also want to talk about cardiovascular disease. And this is also a time when cardiovascular disease risk is increasing for women. So there are contraindications to hormonal therapy. Sorry, just to mention there to close that out is that you have to make sure there's no history of VTE, manage hypertension, but it's not a contraindication. Make sure there's no personal history of breast cancer, no active liver disease, or unexplained vaginal bleeding. Vaginal estrogen can be used anytime. So if you have a woman who's beyond that 10-year window and she's suffering from genital urinary syndrome of menopause, she could still have vaginal estrogen. But what do my patients come in asking me about? They talk about their weight distribution. People talk about this menopausal middle, that the fat distribution kind of reshuffles to the midsection, and women gain weight. And we know that visceral fat also puts them at risk for cardiovascular disease. Of course, they come in asking about skin and hair changes. And that's a helpful sort of thing to know that this is confirming your suspicion that she's going through perimenopause or menopause. And those hot flashes, of course, we talked about them being more commonly mentioned. 75% of perimenopausal women experience vasomotor symptoms. They may be a few episodes, they may be many, they might be keeping them up at night, they may be severe or mild. We know for our patients of color, sadly, that they experience more severe hot flashes and for longer. So as the median length of time that hot flashes continue for women on average is 7.4 years, but for Black women, it's 10 years. So we need to really tune into our patients and ask them about their symptoms if they're not volunteering. Same thing with mood changes. I didn't put a percentage of incidence here because I found percentages as low as, 18% and as high as 90%. And so I do think that it's very common to find depression and anxiety during perimenopause and menopause. And we probably don't know the true incidence because it's understudied. But thankfully, Dr. Conklin is doing that work. So to get back to the cardiovascular changes, we do see that estrogen levels, as they're decreasing, we see LDL changing, triglycerides changing, HDL actually decreases, and metabolic syndrome risks increase dramatically during this time. Blood pressure starts to sneak up on people. Again, kind of linking it back to another time in your life. If you know that patient had preeclampsia or hypertension during pregnancy, she is at higher risk for having hypertension during perimenopause and menopause. We know that there's oxidative stress and there's a whole actual change happening to blood vessels and vasculature. And this, cardiovascular disease is actually the largest killer for women, even though there's so many other risks out there. And the key time for a woman to reduce cardiovascular risk really could be during perimenopause if we're to think of it a little bit differently and be aware of these sort of silent killers, and try to hone in during this time. I didn't want to lecture you guys about all the different cardiovascular modifications that can be made. I think this is a field that is pretty well studied, but at the same time is understudied for perimenopausal women. I think about my average perimenopausal patient, and she has a full-time job. She has kids at home. She might start be taking care of her elderly parents, and to tell her she needs to start working out. 5 days a week is not going to be realistic for her. So I do think this is an area where I'm hoping to do more research myself and with several of you who are here on the call today to try to find a way to make things more realistic for women and to help them combat these changes that are happening during that time. My last slide, and then we can talk for a few minutes, is, I think about this patient, HT, and I definitely am going to talk to her about hormonal treatment, and especially with the heavy bleeding, I might offer her, for example, an IUD with an estradiol patch and see how she does with that. But this is another great opportunity to start talking to her about cardiovascular risks and, how can we tie that into her care. So those are all the slides that I prepared, but I'd love to
I'll read
chat.
some of these questions. First
Okay.
of all, all of this information is so interesting, and it demonstrates how complicated perimenopause and menopause is. That transition, you are bringing to light a lot of areas we need to really pay attention to. So I
Great.
appreciate that. Thank you.
Yeah, thank you.
So, the question is, how can HRTs impact on cardiac and bone health be replicated in women who cannot take estrogen?
Yeah, that's a great question. Honestly, a lot of the cardiovascular health interventions that we have in modern day medicine are hugely effective. And so getting in with a primary care physician or a cardiologist to have a preventive care visit, I think is really important to see what your own risks are. Maybe you need to start a statin. Maybe you need to be reducing salt in your diet. We know that the Mediterranean diet with low sodium is the best thing for hearts. We think that must be true for women in perimenopause also. And so just because if someone is on estrogen, it's not going to make all their other cardiovascular risks zero, right? And we also have to remember the genetics, how they play into it. So there's a lot of modifiable risks that we can take into our own hands. And I would say start with a preventive visit to get your own sort of analysis of if your blood pressure, your cholesterol, all of those sorts of basic things, if there's anything that could be done to improve upon them. And then working in that, Mediterranean low salt sodium diet, I think is really important. For bone health, we need resistance exercise. So, I tell my patients who love to swimming is great for your heart, but it's not great for your bones. You need something that's going to give you this rebound on your bones. And so, this is a time to start working on strength training, where many women are not accustomed to strength training. Building that lean muscle will help to preserve bone health as well. And so it's a completely different way of working out. Dr. Conklin and I were talking about a gym that we both like to go to, and you don't typically see the women in the weightlifting section, right? But it is something that we need to start doing, especially in perimenopause, in order to maintain bone density and bone health. And then, of course, there's medications if a person is already in the osteopenic or osteoporotic range.
Yeah, it's kind of good to have options that are in your control,
Yes.
and then women don't feel so helpless, right?
Yes.
So here's another question. If an individual is overall very healthy,
Mhm.
exercising, good nutrition, and menopausal symptoms are minimal, is
Yeah.
HRT still recommended for the health benefits? In
Yeah.
other words, without contraindications, should most women get HRT?
People ask me all the time. I don't think that estrogen should be in the water. I think fluoride should stay in the water. There's a lot of like public health implications that we're looking into when we see some of these research results come back about hormones and cognition or hormones and heart health. I think we haven't seen it all play out yet. I do think that there are probably more benefits than risks, and we still just don't have all that research laid out yet. So when I have a patient who's not symptomatic, I really do kind of think through with them, well, I can't guarantee you the benefit. There's a lot of people on social media who are trying to raise awareness about the, potential benefits, but we don't have as much robust research on this as I feel like it sounds on social media. But I do think that if you don't have medical contraindications, then it's not unreasonable if you want to try it, right? So a lot of women are on oral contraceptive pills during this time for contraception, and we're really not concerned about their exposure to the estrogen and progestins that are in those. So if you don't have medical contraindications and you are curious to see how you do on hormone therapy, I think it's reasonable, but I can't promise that benefit of longevity and all these other things because we just don't have all that research yet. Oh, I like this
So
question about strength
we
training.
have another question, and but thank you for that. Yeah, it is,
Yeah.
like you said, it's so complicated, and we definitely need more research.
Yeah.
So another question here: how can we encourage more women to pursue strength training?
Yeah, I think we need more examples of how to do it. I think it's not like Olympic lifting, right? And a lot of women don't want to bulk up. And I hear patients say that, like they're happy to do the cardio workouts, but they don't want to bulk up with muscle. Well, It's pretty hard to actually bulk up. You need to be consuming a lot of protein. You need to be lifting very heavy to actually truly bulk up. But for lots of women, you could do 15-pound weights, which would be hugely helpful and also just, help with toning. But how to even get started with that is, I think, the question that, one of those questions I want to try to figure out how to answer because as a gynecologist, when I'm seeing these patients in my office, I don't typically have the time or even the setting to say like, here, I'm going to show you how to start your strength training. I tell them I want them to do strength training. And, ideally for everyone who has resources, it'd be great to hire a personal trainer so then they can work with you to build things up. But I am really interested in figuring out how can we scale this so that you're teaching somebody to start from the very beginning of how do you start off with strength training? Do you start with resistance bands? Do you start with 2 pounds and then work up to 15 pounds, right? And trying to make that in a way that's digestible for people is something I'm really interested in.
Yeah, that's really a really good point. And, because I, like you, or, hearing a lot of women, they don't really know where to begin, how to start. So
Yeah.
thank you for pointing all that out. So Dr. Pope, you provided us with a lot of good information and a lot of things to think about. And we really appreciate you taking time out of your morning um, to talk to us today. And so it, there's no more questions. And just thank you very much.
Thank you. Thanks for having me.